Welcome to the presentation on crisis management at the federal level in health emergencies by the Coordinated Medical Service of the Swiss Armed Forces. In this presentation, we will look at the three main topics. One is public health in health emergencies, just to give you a bit of an overview over the topic in terms of the process, like to show you the different roles on the federal level in Switzerland is the second part. And in the end, we're going to look at how this worked in the COVID-19 pandemic, as well as some lessons learned of what can be improved in the future. So in terms of public health, it's about weighing many different interests. So on one hand, you have medical interests, such as want to get people healthy, prevent people from dying. Then there are logistical issues in terms of resources to have the right amount of PPE available. Then legal issues, legal challenges where you have who's responsible for what, social challenges where different social groups might be impacted by an emergency in different ways, and you have to weigh the different interests of those social groups. And then you have economical interests, how the economy fares during an emergency, and most often those are conflicting, so you have to weigh which is more important at this moment. And so this is what is challenging about public health. And one example is in terms of the COVID pandemic response is here in this chart. You have the GDP growth, meaning that the lower a country is, the more economic damage has the country suffered. This is measured in terms of GDP compared in Q2 of 2020 to Q2 of 2019. In terms of the further right country is, the more death the country has experienced due to COVID, and this is measured in death per million on September 30th, 2020. So what we can see here on top left corner, you have what could be considered good responses. So here you have Korea, for example, which had a very good response, New Zealand, Germany, and Switzerland is also in the group, although in the right bottom edge of good responses. Here we can see, for example, that New Zealand and Korea had very, very few deaths, but for example, Korea also, through their response, had a much lower economic impact. This also has to do to a certain degree that the pandemic in Korea was a bit earlier, so the recovery is already a bit further. But Switzerland basically places roughly at a 10% GDP reduction and 200 deaths per million at the moment. On the bottom right corner, you see countries clustered that have more of a poor response. Here you have countries like the United States, Brazil, Great Britain, Italy, and France, which have much higher death rates measured by population, but also in the majority of cases higher decrease in GDP when you compare between 2019 and 2020. So that also shows, for example, that there is not so much of a trade-off between economy and health in this case, because without an adequate response to the health challenges, the economy will suffer regardless. So here you have, for example, the United States that was very liberal in terms of implementing lockdowns in certain parts, still suffering about the same economic damage as Switzerland, that has been more stringent in terms of implementing a lockdown. But then obviously there are other countries that had much more stringent lockdowns and that, for example, didn't suffer as much in terms of economic lockdown. But then you also have, for example, Korea, where there was very little in terms of lockdown. They just had a very effective contact tracing, and that's why they have not as much GDP reduction as other countries. What are challenges in crisis management in terms of health crisis? Well, one thing is that expertise is usually available. We have many different groups of people, like scientists and health officials, that are very good at analyzing the situation and bringing in their knowledge. And we have in Switzerland, we have very high levels of education, high levels of training. Crisis situations are trained on a regular basis. So there are many people that know they can give advice in terms of different aspects of a crisis. However, then balancing these different expertise and sometimes managing the contradictory recommendations and advice that is produced is much more difficult. So you can't always go with the point of view of one group, because otherwise other groups might feel neglected and not participate in the management of the crisis as much. So that is one of the challenges. And then there's also different interest groups, as I said, like, for example, economic interest groups that represent their members, and then you have health interest groups that represent their members, which is equally challenging, particularly in a country like Switzerland with a federal system where the cantons have a very strong voice. And so balancing the different interests of the cantons and making sure that the cantons don't just look for themselves is a very challenging task and a very important task to have effective crisis management. Another aspect, which we'll look at in a moment, is that these decisions in the moment are based on assumptions, because we don't know how the crisis will develop in the future. We have to make assumptions how it will develop and what is going to happen, and based on that, we have to make decisions today. And then sometimes we learn during the process of managing the crisis that those assumptions were wrong and that we corrected it, and then we adjust our decision making. And we also have to make sure that the decisions are fair, so nobody is discriminated, nobody feels discriminated against, because obviously unity and trust in the decisions is a major factor when it comes, for example, to the population as a whole. The more you trust the government, the more you will follow the advice that the government provides, and the more effective the response is going to be, which is something that in Switzerland, for example, has shown that Swiss people were very good at adhering to the recommendations and the policies that were implemented. And this in this aspect also there is that the communication of the decisions has to be very clear and simple and easy to understand so that people can follow it. And we will not look at those two last points because they were more done, for example, by the Federal Office of Public Health, but those are very, very important aspects in crisis management. So an example of assumptions is here, where we have a model, and we have on one hand we have on the top we have how the virus or how the pandemic could develop over time without any intervention. So there we would have a peak on day 76, and then we have the comparison of this where there is an intervention between days 50 and 80, and that shows that the peak is moved back by 27 days. Now, obviously, like in this model, we would have the assumption that the moment that those measures are ended, the population would go back to business as usual and will behave exactly the same way as it has before those measures were taken, which obviously we know has not been the case. So what this shows is, for example, there was the assumption that we implement measures like social distancing and self-quarantining and so on over a period of time, and use that time to make structural changes to how the system works, how people behave, sensibilize people, so that then when those measures are lifted or reduced, then there is a change in behavior that then is less conducive to a spread of the virus, such as shown here. And this has actually worked, because after social distancing measures have been lifted and reduced, we have not seen a very strong spike. We have seen a continuous progression, and we don't know where it goes now in October, but there has been a change of behavior, and people are more conscientious about washing hands and generally like how they interact with people. And so this has been quite effective. And obviously now we also have masks in public transportation. And so we have different measures that limit the spread of the virus. But it's always, we don't know exactly how effective those measures are going to be. So at the same time as we are developing measures to reduce the spread of the virus, we also have to look at scenarios where, for example, the policies do not have the desired effect and they are not as effective as we have hoped. So we also have to make sure that the resources are ready. So we have to, for example, buy respirators and store respirators for a case where those policies are not as effective as they were assumed to be. And so this then sometimes results in a situation where you stock up on resources such as PPE or respirators, and then the policies work, and then you don't actually need those resources. But it's better to have those resources and not need them than to need them and not have them. So you're preparing for scenarios that you're trying to avoid while doing everything to make sure that they never happen. And so this is some of the difficulties sometimes when it comes to making decisions in the moment. And then when you look at it from a couple of months later, and you see, okay, this was not necessary, but in the moment, based on assumptions that people have made, it was necessary, and it was probably the best decision. And this has been discussed by all the experts involved. So in terms of process and roles, there are three stages to a crisis. So there is prevention preparation. So there you're trying to make sure that you know a lot about, you know as much as possible about what could potentially happen, and you implement policies in terms of, for example, also training like different crisis management staff to make sure that as much as possible you're ready, and as much as possible crises won't happen. But then in case they do happen, then there is the execution phase, where you have on one hand the place of event, which in case of, for example, an airplane crash would be very focused. In terms of a pandemic, it would be very widespread. Then you have the transport aspect of it, so you have to get injured people to the hospital. You have hospital care with the capacities in hospitals, and then you have rehabilitation where people are nursed back to health. And once that execution aspect, so the crisis has been managed, then there is also a recovery phase, which is very, very important, where you replenish resources, both in terms of manpower, in terms of other resources like PPE or personal protective equipment, or like the system as a whole, where you make sure that the system gets back to a state where it can deal with another crisis. And then you have the evaluation phase, which comes at the end, or is actually more continuous, as we will see in the lessons learned, where you draw learnings from how the crisis has been managed, and make sure that you learn enough to improve in terms of future crises. And in terms of roles, there's obviously there are leadership roles. These are those people that make decisions, that decide what is going to happen. Then there are core roles in terms of they have a coordinating function that way different interests that communicate the needs of different departments of different institutions. And then there's implementation roles. Those are the frontline workers. Those are medical doctors. They're nurses. But they're also police or fire brigades, and sometimes the army, as we will see in the case of COVID-19. And so those are the different roles that you have in crisis management. And in terms of on a federal level, from the point of the coordinated medical service and the army, just a couple of examples here. We will not go through all of them. You have the KSD, the coordinated medical service, which is coordinating function in terms of making sure that the analyses are done and the knowledge is shared between the different institutions in terms of execution. There is coordination, such as, for example, how many beds are available where, and how they are in hospital beds, and how they can be used, and in terms of evaluation, making sure that the lessons learned are distributed through the different institutions. In terms of army, you have, for example, the medical troops, which are involved in supporting civilians if that is necessary in terms of hospital care and rehabilitation. You also have different capabilities in the army, for example, the rescue troops, which are more sort of engineers, so they are involved when the place of event, for example, when people are trapped under rubble, when there is an earthquake and bridges are damaged and those kind of things. So there, the army has capabilities for that. But then there is also civilian aspects, like, for example, civil service. They can support hospital care and rehabilitation. And then you have the Civil Protection Service, which is actually in a different color because that's not on a federal level. That is in the domain of the cantons. So every canton has Civil Protection Service and can use it to support the civilian structures like medical personnel. And they are also involved throughout the execution and the recovery of in crisis management. Some examples. So here, these are the medical transport trucks of the army, and here you can see there is those are both civilian medical personnel and army personnel, as well as civil protection service personnel, working together using the transport means of the army in this case. So it's obviously beneficial to have this additional resources, where then if the civilian resources do not suffice, the army can support that the civilians in terms of transporting patients and injured people. So this leads me over to the next point, which is what is the role of the Swiss Armed Forces in crisis management, and with a particular focus on health crises. And there are two main points. One is training, and one is medical, which we will look at in more depth afterwards. And then there is also in terms of crisis management. So a lot of crisis management staff has had some army training, which means that most of the people distributed in cantonal crisis management staffs and federal crisis management staffs have a similar background and a similar language to communicate, use similar abbreviations, mean the same things when they say something. So this helps in terms of communication, because communication under pressure is obviously something that is very challenging. And then the other main point is additional resources, as we have seen, for example, in with transportation before. So in terms of the medical training, in the army, we train medical doctors. So this is like, as you know, Switzerland has a draft army, which brings people from who are experts in the field in civilian life into the army, and then the army can train them on additional skills. So in the case of medical doctors, for example, in the army, medical doctors are trained on preclinical emergency medicine that is recognized worldwide. And so this obviously provides medical doctors with additional skills in case of accidents or other trauma, even if you are not in a specialty that deals with those things on a daily basis. And also in the Army, you will receive experience in triage and leadership training. And those are skills that are very valuable to have distributed amongst the population, because in crisis management, sometimes doctors might end up in positions where they were not initially prepared for, and then they have this additional skill set, and it's very valuable to have that distributed amongst the population to make the response as flexible as possible. In terms of specific training, to give you an overview over the benefits as well, like if you were to serve in the Army, the Army provides you with the opportunity to get certificates that can otherwise only be obtained at a later point in your careers, and it usually costs quite a bit of money. And also the recognition of the Haveli Practicum, which is like basic internship, as I understand it. And the important thing is the military service can be completed alongside your studies. There doesn't need to be a gap year. You don't have to be you don't have to pause your studies for a year to do the military service. So this works in parallel. And an important point for me and everybody in the Army is that being a draft Army, the objective is to choose from the best people, regardless of where they come from. So we want to have the best doctors in the Army, and so I want to stress. I would like to stress that this training is also open to women. And women are welcome in all aspects of the Army, but since we're talking about medical doctors here, particularly here, because it doesn't matter if it's a female doctor or a male doctor. It's important that we have people with skills in triage, in preclinical emergency medicine, everywhere. So it's also obviously for us it's important because 70% of the students are female, of medical students are female. So we would like to invite everybody to consider serving as an Army doctor. And if you are interested, you can find more information here in those two links that I provide in the slide. And if you have any questions, my email is at the end of this presentation, and you don't hesitate to send me an email. So in terms of additional resources, it's important to know that health systems are organized by cantons. So every canton manages their hospitals by themselves. And so in case there is a large-scale emergency, no canton has the resources to handle it by themselves because they are focused on their business as usual. And so if there is something that has many injured or a pandemic that has many infected, then the canton won't be able to deal with it by themselves. So there needs to be coordination at the federal level that coordinates resources like manpower and personal protective equipment and infrastructure to support the cantons. So there's obviously neighboring cantons can help, and then there's also the federal government that can help. And if the civilian resources are insufficient, so the neighboring cantons are helping, but it's not enough, then the Army comes in subsidiary means and supports the health system in a medical emergency, or supports any other aspects in terms of, for example, the rescue troops, or when there is security needs, the military police can support the civilian police, and many other ways. But here we're going to focus on the medical troops. So if it's determined, if the Federal Council determines that there is need for the army to support the civilian health system, then the army has different means, different types of troops that can be mobilized, and they can be mobilized quite fast. So in the first stage, you have the Durchdiener, which are those soldiers that do their service in one go, so they don't have the basic training and then repetition courses. They take about 48 hours for mobilization, and then they're ready to be deployed. Then in the next stage, there are different battalions in terms of medical, in terms of hospitalization troops, and then also a logistics battalion. And those are people that are in civilian life, and then they get mobilized, and they go to the army. They are received. They receive some preparatory training, and within 96 hours they are ready to be deployed. And then there is also the reserve, but the reserve takes much longer, and we will not talk about this here. So one example of resources that the Army has. So this is these are a couple of pictures of a field hospital that can be built anywhere where there is enough space. This field hospital can be used for triage and then patient care. It also has an operations room for 2 patients, so they can be emergency surgery can be done there, and this is obviously a very flexible tool to have in the arsenal, and if it's necessary, then it can be deployed in those 96 hours. So moving on to the example of COVID, what we've learned is that the process works as planned or as trained. So the goal of 96 hours to be ready for mission has been achieved. So when the order from the Federal Council came, for example, the Hospitalization Battalion 75 was mobilized. Then, so on the day 1, so people moved to the location where they gathered. Day 2 was mission-focused training. So this involved COVID-specific information, some refresher of what people have learned in the basic training. And then day 3 and 4, people were ready for mission, and in coordination with the needs from cantons and hospitals, they were deployed in groups to support specific hospitals, specific medical institutions, care homes, wherever there was a need for support. And it has shown that people that were not necessarily in the medical field, this could be researchers, for example, came in, and after a short refreshment of the training, they could be deployed in support of nurses and doctors throughout the country, which is like basically shows that the system works. It's also one example of challenges that Army doctors faced is that the Army issued an order not to release soldiers from service. So in normal times, when there is no crisis, if you have a small ailment, then sometimes the doctors can decide, okay, we don't need you right now, so you can get better at home. However, in the case of COVID, it was ordered that those people are not released, because obviously you didn't want to have too many people traveling throughout the country, and we also needed every man and woman that was available. So as an Army doctor, for example, here you obviously have to deal with a trade-off between what is the mission. So how many people do we need to complete those missions? You have the welfare of the unit, so you have to make sure that everybody in the unit is well, and then you also have the individual welfare. And so in civilian life, for example, the focus would be more on the individual welfare. So you have this patient, you have to make sure that this patient gets healthy. This specific ailment has to be repaired. But as in the army, you have those three sometimes competing objectives, and you have to balance out what is more important right now. Is the individual welfare more important than the mission? And depending on the ailment, this might be more towards the mission. And so this is a different type of approach in terms of medicine, and it's sort of a broadening of horizon challenge for people that have trained in medicine. So a couple of images as well here from the COVID support from the army. So you had members of the Swiss Armed Forces supporting in hospitals with basic tasks. Obviously, those are not experienced nurses, so they are not replacing experienced nurses, but they can support nurses and doctors in basic medical procedures, and for example also take care of the patients and those kind of things. So like very basic stuff. But when the pressure is very high in the system, as in the case of COVID, then this obviously is a big relief, so that the system doesn't collapse. But also just another example is the military police helping the border patrols, because we closed the border for a moment, and then you had the military police support the border police to deal with the additional requirements of that situation. So moving on to lessons learned, what we know is that the deferment of elective medical procedures, so surgeries, for example, that could be planned, were delayed, and the use of temporary structures, so there were additional hospital beds in different locations, that response was sufficient. So at no point in Switzerland, the hospital, we didn't have enough ICU beds for COVID patients that needed an ICU. So in that sense, it was the system worked. What we've also learned is that there is surge capacity in terms of hospitals. There are some subterranean hospitals from the army that proved to be not of sufficient quality and also didn't have enough medical staff. Here, it's also important to know, obviously, that in the specific case of COVID, it was not very it was not prudent to put COVID-infected people in subterranean hospitals. So some of the equipment and some of the beds that were in those subterranean hospitals were then transferred to other locations, into temporary locations and temporary hospitals where they could be used above ground, because obviously in terms of a pandemic, it's much better to have hospitals above ground. So this is one lesson learned. Then second lesson learned is also that the first pools that were activated in terms of having surge medical staff, additional medical staff, was students that were towards the end of their studies and recently retired medical personnel. And it was also managed internally, so vacations were delayed, there was overtime accumulated and things like that, and there was some support from under-occupied hospitals to public hospitals that needed staff. However, most of these measures were taken in the moment without much planning, which is obviously always very difficult when you have to improvise when you're already under pressure and you have many more patients than what you anticipated, and you have to deal with this like this. But one important thing is here: the recovery of resources will be a challenge, because if somebody, for example, works overtime over a long period of time because of a crisis situation, it's going to take them time to recover so that they don't burn out, for example. And vacations, for example, even if they're delayed, at some point they have to be taken. And so at some point, we have to take the system and place it in a in a state where it has some space again to address another situation, and so to take the pressure off the system. And this is going to be, for example, a challenge with overtime that has to be compensated, and so on and so forth, which is something that obviously is just about to happen. And this is not just for the medical personnel. This is also crisis management staff in public administration and different institutions across the country, where a lot of time has been invested into dealing with COVID, and obviously those people need to recover at some point, and this is something that will have to be dealt with. Third lesson learned is the Army surge capacity was necessary, so it was necessary to deploy soldiers in support of the civilian systems, on top of what we've already seen. Important here is to know that the vast majority of the 2,400 soldiers that were actually deployed did not work in the health system in civilian life. So those were, again, people from different fields. And here it's also important that medical staff that was in those units but was needed by the hospitals could request that they were released and they were sent back to their hospital, because obviously then they could be more effective there. So this is actually some true reserve, so additional capacity. And the KSD, Coordinated Medical Service, also coordinated surge capacity in laboratory specialists. Obviously with COVID you had a lot more analysis that had to be done, and so there were more people needed in laboratories. There was also other medical support, like the Samaritans, for example, that could be activated and coordinated through the KSD, and pharmaceutical students in terms of support of pharmaceutical aspects and for example, production of medicine and so on. Fourth lesson learned, one important thing here as well is that during the COVID-19 response, it was established that there is a single point of procurement and distribution, and that was the military pharmacy, which was very important because, again, the cantons have the dominion over their health system. So if they have to procure their own material, then they can do it at a smaller scale, and also they might end up in competition with each other. But this is something that we've seen, for example, in the United States, where different states were competing for respirators, for PPE, against each other and outbidding each other. And this is obviously a massive waste of resources, and it's not conducive to good crisis response, because obviously the more people coordinate, the more effectively these resources can be used. And in the case of Switzerland, so since this equipment and medical material was procured by the military pharmacy, then afterwards there was coordination between cantons and the coordinated medical service to determine which canton needs what, and then we could provide them with the resources they needed, and that way all the cantons had resources, and they didn't need to spend a lot of time trying to find masks in a market where it's very, very difficult to find masks. Because everybody, obviously, all over the world was trying to buy masks. And so this was also a very, very effective way of addressing this pandemic effectively. So in conclusion, so we've seen there are those three stages in terms of Corona. We are now in the first wave. We are sort of through the execution. The levels have come down. Some policies have been lifted. Hospitals have more availability again, and now we are in the point of replenishing resources. So obviously, in terms of lessons learned, as you could see, there was more in terms of prevention. What can be done better to make sure that we are better prepared and can prevent a pandemic like this? And in execution, what can we do better during the execution? In terms of recovery, there are not that many lessons learned yet because we are still in this process, which is also important because obviously we have seen the numbers of cases rising over the last few weeks. So there might or might not be a second wave. So there is obviously analysis going on, and there is policies prepared, like for example mask wearing, to make sure to try to avoid as best as we can that there is going to be a second wave. And how this develops is something we don't know, and we will see over the next couple of months. Yeah. So thank you very much for your attention. I hope this was interesting to you. If you have feedback or questions, don't hesitate to contact me. My email is on this slide. I'm very much looking forward to your questions. I will also be available for during the conference to see to have maybe further in-depth discussions. And thank you very much.